Initial assessment and APGAR scoring. The initial assessment of the neonate is performed immediately after birth as the nurse conducts a brief physical examination. And it's brief, we want that baby to have skin-to-skin contact with mommy as soon as possible. Let's talk about this initial physical assessment. The initial examination of the newborn may be accomplished while the infant is lying on the mother's abdomen or chest or in her arms immediately after birth, or alternatively, while the newborn is lying on the radiant warmer bed. If the newborn is breathing effectively, is pink, has no apparent life-threatening anomalies or risk factors requiring immediate attention, further examination can be delayed until after the parents have had an opportunity to interact with the infant. Ideally, the newborn remains skin to skin with the mother for at least the first 1 to 2 hours after birth. Where was I? The first 1 to 2 hours after birth, and breastfeeding is initiated during that time. And you guys know we're always going to encourage mom to breastfeed instead of formula as much as possible. APGAR score. The APGAR score, this is a routine rapid assessment of the newborn's overall status and response to resuscitation. This assessment tool is based on 5 signs that indicate physiologic state of the neonate. Now, before we go over that, I want you guys to take a look at the bottom of this page where they go for APGAR scores. Look at what they're looking at. The heart rate, respiratory effort, muscle tone, reflex irritability, and color. You see this growth chart? What's normal is the 10th to 90th percentile. That's normal, okay? And here, this is the same thing we went over the box. So isn't that interesting? We're seeing in text what they're looking for in the APGAR scoring, and we saw in the box as well. The heart, the respiratory effort, muscle tone, reflex irritability, skin color. Ten is the highest that you can get. APGAR scores of 0 to 3 indicate severe distress. Scores of 4 to 6 indicate moderate difficulty, and scores 7 to 10 indicate that the newborn is having minimal or no difficulty adjusting to extrauterine life. An APGAR score is assigned, you guys have to know this for testing, at 1 minute and then at 5 minutes after birth. 2 times, at 1 minute and then 5 minutes. Physical assessments of the newborn. Blood pressure. Term newborn of average weight, about 60 to 80 over 40 to 50. That's the average blood pressure. Systolic, 60 to 80, diastolic, 40 to 50. Weight, for a female term, about 3,400 grams, male, 3,500 grams. In regards to weight, we're going to weigh the patient at the same time. Same type of clothes, which is nothing but the diaper. And if it's a diaper, we have to weigh the diaper, right? Same time each day, protect newborn from heat loss. Weighing the infant. The nurse never leaves the infant alone on the scale. The scale is covered to protect against cross-infection. Skin. Skin should be generally pink. Acrocyanosis, common for the first 48 hours after birth, not central cyanosis. Do not get tricked. The patient's head. All right, expected findings. Palpable and separated sutures. Deviations from the norm. Full or bulging may indicate tumor, hemorrhage, or infection. If it's depressed, that may indicate dehydration. Genitalia. Expected finding for the clitoris, usually edematous. Labia majora, usually edematous. And if the parents are concerned, just let them know that that swelling is going to go down. It's just the hormones with birth. Page 553. Classification of newborns by gestational age and birth weight. The infant whose weight is appropriate for gestational age, that's the birth weight between 10 to 90th percentile, that's what's normal, guys, can be presumed to have grown at a normal rate regardless of the length of gestation. The infant who is large for gestational age can be presumed to have grown at an accelerated rate during intrauterine life. The small for gestational age infant can be presumed to have grown at a restricted rate during intrauterine life. So with the small for gestational age, it's going to be less than the 10th percentile. And for the large for gestational age, it's going to be higher than that 90th percentile, because remember the norm is at 10 to 90th percentile. Just know these definitions, classification of newborns according to gestational age. So you know what they're talking about, if they're talking about the premature versus the early term versus the late term infant. Post-term or post-mature infant. Infants that are born at 42 weeks gestation or beyond are considered post-term, regardless of the birth weight. These infants are labeled as post-mature, and they're likely to have little, if any, vernix caseosa, absence of lanugo. Remember, lanugo is those fine hairs that they're born with. Abundant scalp hair and long fingernails. The skin is often cracked, parchment-like, and peeling. On the side I wrote, look old. They look like an old person. A common finding in post-mature infants is a wasted physical appearance that reflects placental insufficiency. Depletion of subcutaneous fat gives them a thin, elongated appearance. The scant amounts of vernix caseosa that remains in the skin folds may be stained deep yellow or green, which is usually indication of meconium in the amniotic fluid. Remember that meconium, they're supposed to have that after birth. They're especially prone to fetal distress associated with placental insufficiency, macrosomia, and meconium aspiration syndrome. Airway maintenance. If the airway is obstructed, then the mouth and nasal passages can be gently suctioned with a bulb syringe. Notice it said if the airway is obstructed. We don't do this routinely anymore. We used to. Vigorous suctioning should be avoided. It can cause trauma to fragile tissues. Routine chest percussion and suctioning of healthy term or late preterm infants should be avoided. We only do it if we need to. It's not going to be routine. Suctioning with bulb syringe. Make sure that you keep that bulb easily accessible and visible. Suction the mouth before the nose. This prevents the infant from inhaling pharyngeal secretion. You want to compress the bulb and then insert the tip into one side of the mouth. Avoid the center of the infant's mouth because the gag reflex can be stimulated. Gently suction nasal passages in one nostril at a time. Stop suctioning when the airway is no longer obstructed. Clean the bulb syringe with warm soapy water and make sure you rinse it thoroughly each use. Maintaining an adequate oxygen supply. 4 conditions are essential for maintaining an adequate oxygen supply: a clear airway, effective establishment of respirations, adequate circulation, having enough perfusion, effective cardiac function, and adequate thermal regulation. Preterm infants are at greatest risk for respiratory distress. Why do you think that? One word: surfactant. Very good. All right, maintaining body temperature. Cold stress increases the need for oxygen. It can deplete glucose stores. The infant can react to exposure to cold by increasing the respiratory rate and then becoming cyanotic. The ideal method for promoting warmth and maintaining neonatal body temperature is early skin-to-skin contact. The unclothed, so no clothes on the newborn, the unclothed newborn is placed prone directly on the mother's chest. Both mother and infant are then covered with a warm blanket, and the cap is placed on the infant's head so they don't lose heat through their head. Skin-to-skin contact in the first hour of life increases neonatal blood glucose concentrations, improves temperature stability, results in less crying, and it improves breastfeeding initiation and duration. Skin-to-skin contact and breastfeeding at birth can reduce the mother's risk for postpartum hemorrhage. Because the baby breastfeeding, that causes that uterus to contract, right? Yeah. If the newborn does not remain skin to skin with the mother during the first 1 to 2 hours after birth, the nurse places the thoroughly dried infant under a radiant warmer or in a warm incubator until the body temperature stabilizes. But our first choice is always skin to skin. During all procedures, heat loss must be avoided or minimized for the newborn. Even a healthy term infant can become hypothermic. Inadequate drying and wrapping immediately after birth, being left on wet linens, a cold birthing room, or birth in a car on the way to the birthing facility can cause the newborn's temperature to fall below the normal range, which is known as hypothermia. Let's talk about eye prophylaxis. The U.S. Preventative Task Force recommends instilling a prophylactic agent in the eyes of all newborns to prevent ophthalmia neonatorum or neonatal conjunctivitis. This is an inflammation caused by sexually transmitted bacteria acquired during passage through the mother's birth canal. And here's the thing, we do it even if the baby was born by C-section, okay? Eye prophylaxis is recommended for all newborns regardless of the type of birth. In the US, erythromycin 0.5% ophthalmic ointment is a recommended prophylactic medication to prevent infection from the gonorrhea. Erythromycin, that's their key. Make sure you know it. Eye prophylaxis with erythromycin is bacteriostatic and bactericidal for gonorrhea. Indication to prevent ophthalmia neonatorum from gonorrhea. And this is going to be given in a 1 to 2 centimeter ribbon of ointment on the lower conjunctival sac. And remember, guys, you always go from the inner canthus to the outer. Very important. Nursing consideration. You're going to administer within 1 to 2 hours after birth. Make sure you wear gloves. Do not touch to the eye. Okay? All right, moving on. Vitamin K. Oh, sorry, you can see? No problem. Can I move on? Yes. All right. Vitamin K prophylaxis. At birth, neonates have low vitamin K related to limited placental transfer of vitamin K and the lack of normal intestinal flora necessary for vitamin K synthesis. Well, vitamin K, that's the antidote for what? Warfarin, yes, thank you. Coagulation, Coumadin, right? So we know vitamin K is very important, excuse me, when it comes with clotting. Let's keep going. Look at what it says. Newborns are able to produce, by 7 days of age, healthy newborns are able to produce their own vitamin K. The AAP and ACOG recommends that every newborn receive a single dose of I'm not going to pronounce this medication, but this is type vitamin K, 0.5 to 1 milligram to prevent vitamin K deficiency bleeding. Administration of this injection should be delayed to allow infant to spend some skin-to-skin time with the parents and for the first breastfeeding. Number one, after, making sure we prevent hypothermia, we have that patient warm, we want to have them on the mother's chest and we want them to breastfeed. So look at this vitamin K administration, some important things for you guys to know about it. The action, it provides vitamin K because the newborn doesn't have the intestinal flora to produce this vitamin for about a week. Remember, they don't make it until about a week later. It promotes formation of the clotting factors, and we give it to prevent vitamin K deficiency bleeding. How's it given? IM. Not sub-Q, not orally, it's given IM. Remember how earlier we talked about hyperbilirubinemia? Yes, let's talk about the therapies for it now. The decision to treat an infant for hyperbilirubinemia is based on the total serum. What's that B stand for? I'm assuming blood levels. Yes. Total serum blood levels. The infants, what's that? Oh, I was all wrong. Total bilirubin. Just joking, guys. Total bilirubin levels. Remember, it's considered increased if it's higher than what? What's that range? 6 or 7. Very good. The infant's gestational age and the presence of risk factors. So this is what they use to consider if the patient needs to be treated. The goal of treatment of hyperbilirubinemia is to reduce the newborn serum levels of unconjugated bilirubin. There are 2 ways to reduce the unconjugated bilirubin levels, either by phototherapy or exchange blood transfusion. Phototherapy is the most common treatment. Let's talk about phototherapy. During phototherapy using a lamp, the neonate wearing only a diaper is placed under a bank of lights approximately 40 to 50 centimeters from the light source. If phototherapy is effective, the bilirubin level should begin to decrease within 4 to 6 hours after phototherapy has been initiated. And within 24 hours, we should see a decrease by about 30 to 40%. Nursing alert. When a phototherapy lamp is used, the infant's eyes must be protected by an opaque mask. The shield should cover the eyes completely, but not occlude the nares, because remember, they're nose breathers. We want to cover the eyes, but not the nose. Hydration maintenance in the healthy newborn is accomplished through breastfeeding, pasteurized donor milk, or infant formula. Feedings of glucose water or plain water should not be used because these liquids do not promote excretion of bilirubin in the stools. We're trying to get rid of the bilirubin, and remember, it's primarily, that's what it's excreted through the stool. The nurse closely monitors urinary output as an indicator of hydration status while the infant's receiving phototherapy. The number and consistency of stools are monitored. Bilirubin is excreted primarily through the stools. So it's important that the infant is having bowel movements. Nursing alert. When phototherapy lights are used, no ointments, creams, lotions should be applied. You're going to burn them. Infants under phototherapy lights need to be repositioned at least every 2 to 3 hours to maximize skin exposure. All right, let's talk about hypoglycemia. Hypoglycemia in a term infant during early newborn period is defined as blood glucose concentration inadequate to support neurologic organ and tissue function. The lower limit for normal plasma glucose levels during the first 72 hours after birth is often cited as about 40 to 45 milligrams per deciliter. That's the area, around 40 to 45. at birth. The maternal source of glucose is eliminated when the umbilical cord is clamped. I know, I'm so sorry, guys. Don't shoot the messenger. Early and regular feedings promote normal glycemia. We want to promote that breastfeeding as soon as possible. There's no need to routinely assess glucose levels in a healthy term infant. Infants at risk include those who are preterm or late preterm, small for gestational age, large for gestational age, low birth weight, infants of mothers with diabetes. Matter of fact, you see this one, infants of mothers with diabetes, that's been seen on NCLEX many times. Hold on, let me put a star next to that. I had a pen.
On the side.
On the side?
Yep.
Oh, thank you. That's been seen many times where they'll give you a situation and they tell you that the mom had either diabetes or gestational diabetes, and then they'll give you symptoms of hypoglycemia, or they won't even give you any symptoms, but they expect you to assess that child for possible hypoglycemia. That's a big one, okay? Infants of mothers with diabetes, infants who experience perinatal stress such as asphyxia, cold stress, or respiratory distress. Glucose levels should be measured in all newborns with risk factors for hypoglycemia. That's all of these that I just mentioned, okay? These are, if the patient falls into this category, that's when you're going to be routinely assessing them. And in any newborn with clinical manifestations of hypoglycemia. Nurses should observe all newborns for signs of hypoglycemia. Glucose testing should be performed on any infant with clinical signs of hypoglycemia. They said this a million times. These signs can be transient or recurrent and include, you better know this list, jitteriness, lethargy, poor feeding, abnormal cry, hypotonia, temperature instability, hypothermia, respiratory distress, apnea, seizures. It's important to remember that hypoglycemia can be present in the absence of clinical manifestation. Because of the variations in devices and operator techniques, it's recommended that any level less than 45 milligrams per deciliter should be confirmed with a stat serum glucose level depending on facility policy. Because remember, normal is around 40 to 45. So anything less than 45, we're going to just go ahead and get that blood directly. Safety alert. Oh. A heel warmer should be applied prior to every glucose assessment via heel stick. The heel warmer, guys, it helps to bring blood flow to the area and it decreases pain for the patient, okay?
Something like, should you apply ice? That's contraindicated.
Absolutely contraindicated. Correct. Next safety alert. Next page. Interventions. Infection control measures. Always proper hand hygiene is essential. Personnel should wash hands with soap and water or use alcohol-based hand rub in accordance with the hospital infection control policies after every interaction with the patient. Parents should never leave the newborn in the birth facility room without direct supervision. Parents should be instructed to use caution when posting photos of the new baby on the internet and publishing public notices about the birth. And this is somewhere in the book. I'm not reading all that, but I'm going to tell you this. You're also going to teach them that any nurse or anyone in the building that comes to tell them that they're going to take the baby to give the baby a bath or medication, if that is not their nurse, they've never seen that person before, ask for a second staff member to confirm first. Don't just give your baby to that person. Safety alert. Nurses need to closely observe mothers and newborns during skin-to-skin contact, especially during the first few hours after birth. Hepatitis B vaccine. The action is a protective anti-hepatitis B antibody. It induces protective anti-hepatitis B antibodies. The neonatal dosage, you guys don't need to be concerned about the dosage amount, but you need to know that it's given IM within 24 hours after birth, definitely before discharge. That first dose is given in the hospital. Okay, and then 1 to 2 months of age, and then at 6 to 18 months of age. But the first one is given in the hospital, preferably within 24 hours, but definitely before discharge. All right, important things to know about skin-to-skin contact. I'm not going to read all of them. Make sure you know them, but excuse me. You're going to make sure that the face is visible. You want to make sure the patient's breathing. The newborn's nose and mouth are uncovered. You don't want them to be smothered. The newborn's neck is straight and the head is turned to the side in sniffing position. And you guys can look at the rest on your own. Patient teaching for the circumcised newborn at home. What you're going to teach the parents. Teach them to check for bleeding. If bleeding occurs, apply gentle pressure. And if bleeding does not stop with the pressure, notify the healthcare provider immediately. Teach them to observe for urination. The infant should have a wet diaper 2 to 6 times in a day, the first 1 to 2 days after birth, and then at least 6 to 8 times in the 24 hours after 3 to 4 days. You're going to teach them to keep the area clean. Teach them to change the diaper often. Do not use baby wipes. They just had surgery in this area. For 4 to 7 days, apply petroleum to the glands with each diaper. Notice I put a star next to it. You better know that. You're going to teach them about infection control. The glands of the penis is dark red after circumcision, then becomes covered with a yellow exudate in 12 to 24 hours. That is normal. Don't try to remove it. It's going to persist for 2 to 3 days and it's going to go away on its own. You have to warn them. Redness, swelling, discharge, or odor are signs and symptoms of infection and must be reported immediately. And of course, you're going to teach them about providing comfort to the baby. Safety alert. Swathing is important, but they have to do it the right way. Swathing an infant tightly with the legs extended is associated with hip dislocation. The correct way to swaddle an infant is with the hips in slight flexion and abducted, allowing freedom of movement of the knees. It's important that the blanket is not wrapped too tightly. Okay, guys. Okay, just besides this, just a couple more things. You guys can take a picture of. It's not a lot. Or do you want to come take a picture of the book? You want to finish it? You guys willing to stay?
Yes.
All right, let's finish. All right, safe sleep. You're going to teach your parents to always lay the baby flat in bed on his or her back for sleep, naps, and night. Remember, back to sleep, always on the back, right? Room sharing, but not bed sharing. So they can have the baby in the room with them. It's important. They should have the baby in the room with them, but not the same bed. Never put your baby on a cushioned pillow, beanbag, or water bed. They can suffocate. Avoid soft bedding, including bumper pads, blankets, pillows, stuffed toys, and other soft objects. Again, they can suffocate. Do not cover the baby's head with blankets or quilts. Check the baby's crib for safety. Slats should be no more than 2.25 inches apart. The crib mattress should be firm and should fit snugly against the crib rails. We don't want their head getting stuck between the rail and the mattress. Cover the mattress with tight fitting sheet. We don't want that sheet to come off and cover the baby's face. They're not strong enough. They can't move the sheet and they can suffocate. Supervise them during tummy time. So remember how when the baby's going to sleep, take a nap, we don't even put them on the side because something might happen. They might roll over on their face and suffocate. We want them on their back to go to sleep. But during the day, they need tummy time where we put them on their tummy, but we have to watch them. Do not tie anything around the baby's neck, including the pacifiers. Avoid exposing your baby to cigarette or cigar smoke. Key points about car seat safety. Your baby should always be in a rear-facing infant car safety seat. Shoulder harnesses are placed in the slots at or below the level of the infant's shoulder. That's why they're called shoulder harnesses. The harness should be snug and the retainer clip should be placed at the level of the infant's armpits, not the abdomen or neck area. Position the infant at a 45-degree angle in the car seat to prevent slumping and airway obstruction. Remember, they don't have that strength to lift up their neck. Avoid bulky clothing on the infant. Cars with airbags in the front seat. Rear-facing infant seat should never be placed in the front seat. If the infant must ride in the front seat, the airbag must be turned off. And of course, you're going to teach them to read their, car manual. Umbilical cord care. The goal of cord care is to prevent or decrease the risk for hemorrhage and infection. The umbilical cord stump is an excellent medium for bacterial growth and it can become easily infected. So the recommendations for cord care include cleaning the cord with water, using cleanser sparingly if needed to remove debris during the initial bath and with routine bathing. So here's some important things you're going to teach about bathing, cord care, skin care, nail care. Timing. Newborns do not need a bath every day. 3 times a week is enough. We want to prevent heat loss. The temperature of the room should be between 79 to 81 degrees and the bathing area should be free of drafts. The water temperature should be between 100 and 101.8 degrees. Bathe the infant quickly. Expose only a portion of the body at a time and dry them thoroughly because they can lose heat to their body if they're still wet. You want to gather supplies and clothing before starting. Use a mild cleanser with a neutral pH. Use no preservatives in the soap. You want to bathe the baby. Never leave the infant alone or on bath table or in bath water, not even for a second. Test the temperature of the water before exposing the baby to that water. Begin by washing the baby's face with water. Do not use soap on the face. Cleanse the eyes from, again, guys, the inner canthus to the outer canthus, using separate parts of clean washcloth for each eye. Do not use cotton tip swabs because they can cause injury. Wash between the skin folds and make sure you dry thoroughly. Wash the genital area last. Wash hair with baby wrap to limit heat loss. Skincare. If the skin appears dry or cracking, apply an emollient lotion at least once daily. Cord care. You're going to cleanse with plain water around the base of the cord where it joins the skin. Notify the pediatric healthcare provider of any odor, discharge, redness of the skin around the cord. Keep the diaper folded down so that it does not cover the cord. Remember, this is already an area where the patient's at risk for, bacteria or pathogens to accumulate, right? When the cord drops off after about 10 to 14 days, a few small drops of blood may be seen. If there's active bleeding, notify the healthcare provider. Nail care. Do not cut fingernails and toenails immediately after birth. It's so close to the skin, you're going to cut the patient most likely, okay? Apply loosely fitted mitts over each of the baby's hands. Do so as a last resort, however, because it interferes with the baby's ability for self-consolation, sucking on the thumb or finger. The nail should be cut straight across. When they do grow out, you're going to cut straight across. The ideal time to trim the nails is when the infant is sleeping. Genital care. You're going to cleanse the genitalia of infants after avoiding or stooling using disposable diaper wipes. Make sure they don't contain alcohol or soft cloths with water. For girls, the genitalia are cleansed by gently separating the labia and gently wiping from the pubic area to the anus. We always go from front to back. For uncircumcised boys, wash and rinse the penis with soap and warm water. Do not attempt to retract the foreskin. Remember, it's not going to become fully retractable until they're about 3, maybe 4. As soon as the foreskin is partly retractable and the child's old enough, he can be taught self-care. Exposing the buttocks to air can help resolve a diaper rash. And zinc oxide ointments can be used to protect the skin from moisture and excoriation. Signs and symptoms of illness. Bilious, bright green in color emesis. This could be a sign of bowel obstruction and should be reported to the healthcare provider. Diarrhea, having 2 consecutive green watery stools. Increased bowel movement. In a breastfed infant, fewer than 3 stools a day, but in a formula-fed infant, less than 1 stool every other day. The patients who are breastfed, they have stools much more often than formula-fed. Decreased urination, fewer than 6 to 8 wet diapers per day after 3 to 4 days of age. Breathing difficulties, labored breathing with flared nostrils or absence of breathing for more than 15 seconds. Cyanosis, that bluish skin color when accompanying a feeding or not. Lethargy, sleepiness, difficulty waking. Inconsolable crying, bleeding or purulent yellowish drainage or drainage from the eyes.